Hi, you all. Welcome and welcome to those who are online. We are really glad that you are here to talk a little bit about vulnerability and connection and compassion and basically being human in healthcare. So, we are eager to get started this afternoon. And I want to, I guess, first introduce myself. I'm Nicole Piemonte. I am the Associate Dean for Faculty Leadership and a clinical associate professor of medical humanities here at Creighton in the School of Medicine. And I am glad to be here with some of my colleagues and friends. So thank you all for being here. Good to see you. These are my colleagues who will be up here joining me today. I have here Dr. David Bell. Dr. David Bell, MD, PhD. He's super fancy. He is an emergency medicine doc over at Valleywise. So some of you might know him and have had opportunities, some of you students, to rotate with him. He's just a great colleague and friend. And my other friend, Tom Striegel, who is also an emergency medicine doc, also palliative medicine, trained at Valleywise not too long ago, we'll say, and trained at Banner University in palliative medicine and is now at the University of Iowa and flew all the way here this morning to be with you all today. So I'm glad that they're joining me. Go Hawks. All right. So I start some of my talks with this quote. I think it really captures a lot of what we're talking about. And for those of you who have read House of God, you might be surprised that this is from Stephen Bergman, who his pen name was Samuel Shem when he wrote House of God. And those of you who have read it and know about that satirical, but he claims to be a picture of reality about internship, you might be surprised that this is something he said. He says, "How do you learn empathy? Try living through suffering with someone, really living through it, an opportunity we doctors have every day, and all other healthcare professionals have this opportunity every day." The thing is, we haven't been great at talking about suffering in medicine. We've only recently, I would say, have begun to talk about suffering beyond physical pain with patients and talking about existential suffering, psychic and emotional suffering. We are even worse at talking about suffering among healthcare professionals. It is hard to articulate that. And that's something that we want to hopefully courageously talk about with you all today. This article came out in the New York Times, was talking about languishing. We're starting to see languishing popping up in the medical literature, talking about what's happening to healthcare professionals. So rather than talking about burnout, they're talking about languishing. So, what is languishing? According to the author, he says it's the neglected middle child of mental health. It's the void between depression and flourishing and that absence of well being. So, so many people in healthcare and even so many of our students, you might not say, "Hey, I'm clinically depressed," but something is off. Something isn't quite right. And we're certainly not flourishing. And that's what we would describe languishing as. But the author points out that there is a danger is that when you're languishing, you might not even notice it. Right? And you can't catch yourself slipping into solitude. That's happened to so many of us before. But when you can't see your own suffering, you don't seek help. So when you feel like there's nothing acutely wrong with me, there's just something that's off, it can be hard to see your suffering. This is Martha Nussbaum. I love this picture of her from the New Yorker, and she's a famous Aristotelian philosopher. And by famous, I mean however famous you can get as a philosopher nerd, which is like not very famous, but among the philosophers of the world, she's famous. But she says something really important about suffering, which is related to languishing and not noticing the suffering, because it is so important to be able to recognize it in ourselves. So she says compassion requires a sense of your own vulnerability to misfortune or your own suffering. To respond with compassion, I must be willing to entertain the thought that this suffering person might be me. This suffering patient could be me at any moment. She says, I'll be unlikely to have compassion if I'm convinced that I'm above the ordinary lot and no ill can befall me. So sometimes in medicine, and especially in clinical training, it's really easy to say, I'm the clinician, this is the patient. The patient is suffering. I am not. I'm the professional. And when we separate ourselves in that way and we can't tap into our own suffering or our own potential to suffer, it is really hard to have actual compassion for that person in front of you. So, compassion, when we really look at the etymological root of it, I think it helps us better understand what we mean by compassion because we throw compassion around all the time and we don't really stop to think, what do we mean by that term? So, compassion is two words at the Latin roots. Passion, which is the suffering of pain. This is why we hear things like the passion of the Christ. It means enduring pain. And then we have com, which is in combination or union together. So, what does compassion really mean? It literally means the suffering of pain together. So, this isn't pity. This isn't feeling bad for someone. This isn't sympathy. It is co feeling, feeling alongside someone else. That means compassion requires me to be humble enough to look at my own suffering and that I am not different from the patient in front of me. And it requires vulnerability to look at the fact that we too are going to get sick and die. And very few of us want to look at that. So compassion can feel really, really risky. Joanna Shapiro is a medical educator of 30 years. She's also a psychologist. And she says, without acknowledging their shared mortality, frailty, and vulnerability, students will not be able to make much sense about truly caring for other people. That's what we mean by compassion. If we can't get trainees to be able to acknowledge their own frailty and suffering, we can't expect that they're able to have compassion or co feeling for the patients around them. So, this is why I don't think compassion is a skill that we can teach people. It's not behavioral, it's a way of being in the world, it's a posture of openness to the reality that this world is painful and also beautiful, but that we all suffer and we can all experience illness or injury or death. So compassion feels scary and it requires some courage. This is a quote from Arthur Frank. He's a medical sociologist who had a heart attack at 39 and then a cancer diagnosis the next year. And he wrote a book from a sociological perspective, but also his own experience of being ill and what this was like for him. And he says voices of patients are hard for clinicians to hear because they remind us of the conditions of embodiment that most of us would rather forget our own vulnerability to. So he says it's hard to hear the suffering of patients because it reminds us of our mortality and that we suffer too. And it's easier to talk about labs and imaging and what we're going to do to intervene on the biological body than it is to be present with someone who might be sick or dying. This is why we can give into that temptation to have professional distance. And we throw around professionalism like the appropriate thing to do is to be objective and to not feel too much because then I'm not being professional. But is that really maybe a tactic to protect ourselves? To compartmentalize and to protect ourselves from those really uncomfortable feelings and making sure we're checking in to see what we're doing when we take that professional distance because the temptation to protect ourselves can have the opposite effect. If compassion is co feeling and you're protecting yourself from those feelings, then how can you have compassion? This is what leads to disconnection, to languishing, to burnout, because suddenly you're going through the motions and it's a factory line of people that you're getting through to generate RVUs or to get through your day or to shorten up your list. And the protection is ironically not saving yourself from burnout, but causing the burnout because you're feeling nothing at all. When we do that, it prevents the opportunity for post traumatic growth. Okay. So we're used to post traumatic stress disorder and talking about what happens after trauma. But there are some psychologists who talk about when you don't keep people at a distance, when you allow yourself to feel pain, you can actually grow from the terrible things that happen to you. And this isn't trying to be Pollyanna-ish about our suffering or try to find a silver lining. But this is the idea that if we allow ourselves to feel, which we don't do much in healthcare, then you can grow from these experiences. So you can think about people, maybe yourself, when you've gone through hard things and you've grown from it. So maybe you have this increased ability to relate to other people's suffering, or you have this gained appreciation for life, or now you're better able to handle the hard things. Maybe enhanced spirituality, or that there's new possibilities for your life after you went through something really hard. But this isn't always the case. And I can share a story about my own life that I think might capture some of this for you. When I was 19, my mom was diagnosed with advanced ovarian cancer, and I took care of her for 2.5 years before she died. And that was absolutely a traumatic experience for me. Did I have these outcomes? No. I shut down for years. I finished a master's degree. Then I moved away and got a PhD, and it looked like I was flourishing, but I was numb and disconnected and wasn't even choosing my own life. I was just doing what I could to not feel pain and to run from myself. So I had no growth. And it wasn't until all of that caught up with me. And a few years later, my dad was diagnosed with gastric cancer and he died. And I started to feel those emotions and not hide from them. And I hope that it transformed me in some ways where I can now be present with people's pain in a way that I couldn't before. I think a great picture of this is the Japanese art of kintsugi, which is taking broken pottery and putting it back together. And usually they seal the cracks with gold. And this is the idea of picking up the broken pieces and making something potentially even more beautiful, certainly different, but maybe even more beautiful. And what I love about this is the cracks aren't hidden, they're highlighted. And I can't ever get rid of the brokenness that I have. But the brokenness has created maybe something better than before. And that's not to say that I'm grateful my parents died. I'm not. I wish that they didn't. But it did fundamentally change me. But I had to let myself feel that pain. The problem in healthcare is that disengaged care has become the norm. Not feeling those emotions, not experiencing those things with patients, but to just get through your day, which is understandable. The system is so broken. What else are you supposed to do? So, what these authors say is that many of the practices and assumptions of medicine escape suffering. They deny it, objectify it, or even sentimentalize it without really feeling it. I think a good example of this, if you have the opportunity to watch this, I encourage you to do so. I think I made the M2s watch it, sorry. But I encourage you to watch this about physician suicide. So, this is Dominic King, and he says his first year of medical school, he was experiencing horrible depression. He didn't know why. And then someone came into his class and said, physicians have the highest rate of suicide. And he was like, oh, great. You know, um, and so he started, as a good medical student, doing some research, and he found that there is an interrelatedness between suicidality and suicide completion and disconnection, feelings of disconnection. And this terrified him because he said he was learning the art of disconnection in medical school. He learned to disconnect from his friends and family in order to study. He learned to disconnect from his donor body in the anatomy lab in order to cut into it. And he said, this is an exercise in disconnection, so I'm doomed. He said, disconnecting yourself is a defense mechanism that we use in medicine to deal with the horrible things that happen to people. And that is so true. But if that's the defense mechanism, it wasn't working for him. He said that things changed when he became connected to taking care of people. And where did this happen? It happened his second year with a standardized patient, my clinical skills directors, with a standardized patient that he had to break bad news to. And after he broke bad news to a fake patient, she said to him, I hope this never happens to me, and I hope I never get this diagnosis, but if I do, I hope it comes from someone like you. And he said this changed him profoundly, and that what he learned was that connecting to people instead of just taking care of their diseases is what keeps him going and what keeps him going in his career now. Said empathy is the most important skill a physician can have, not technical skills. It's empathy. It keeps you human, it keeps you connected to other people and not shut down, and gives you the opportunity to have post traumatic growth, which I know he did after this experience. So, what we know is burnout is not the same as compassion fatigue. We think that it is. Oh, I'm burnt out because I'm feeling too much. We are burnt out because we're not feeling anything at all, and compassion is what connects us. Compassion fatigue is real. I don't want to pretend that it's not. I think of people during COVID in the ICU taking care of dying people who were dying alone. That is compassion fatigue for sure. That's real. But I think for the most part, what's going on is that distancing ourselves is not working. So we know that increased compassion actually increases well being, job satisfaction, all of these things. And decreased compassion, co feeling, not connecting, actually leads to burnout. So, what can we do? We will quickly go through some of the things that we can do before I hand this over to my colleagues. So, it turns out clinicians don't need to become more resilient. Maybe that's good news for you in here who have been told you just need to become more resilient. What the studies show is that at least physicians have significantly higher resilience scores than the general employed US population. This is what helps them get through medical school or PT school or PA school. This is what helps people get through residency. They're inherently resilient people. We don't need to help them become more resilient. What I think clinicians need is more opportunities for connection with their patients, with each other, and with themselves. So we have to create opportunities for this because they don't exist. If everybody gets caught up in the wheels of healthcare, you're going to connect to no one. That's how the system is built. So we have to be intentional about this. So ways of connecting with patients. You might disagree with me here, but I'm not really a fan of patient-centered care. I know why it exists. But what I would support is if we focused more on relationship centered care, that the patient matters and the clinician matters. And most importantly, their relationship is what matters. Relationship centered care says all of these relationships matter, including the family members that are in the room. And it's founded on four principles. Personhood matters, the patient and yours. Affect and emotion are important. We don't talk about that a lot in healthcare or in healthcare training, but affect and emotion are something to acknowledge and to value. And maintaining genuine relationships is necessary for health of your patients and for you as a clinician. Rita Sharon, she's an MD, PhD too. I forgot the PhD. She she started narrative medicine. She created narrative medicine. She says through authentic engagement with their patients, physicians can cultivate affirmation of human strength, acceptance of human weakness, familiarity with suffering, and the capacity to forgive and be forgiven. We are not telling healthcare students when they're like applying to medical school, you're going to learn the capacity to forgive and be forgiven. We're not talking about that. And yet, that's what's happening. What I think is important here is we focus so much on altruism. You need to kind of experience radical self neglect for the care of the patient. And yes, you do need to have altruism. You don't want to take advantage of your patients. But when we focus so much on altruism, we cover up the fact that clinicians receive so much from their patients. It is a mutual giving and receiving, and altruism has very little to do with it because you do receive something from being with patients. And we need to have connection with each other. An example of this is Schwartz rounds. I've got some people who come to Schwartz rounds. Raise your hand. Yes, my people are here. Schwartz rounds is amazing. This is at the hospital. We do this at St. Joe's. I invite all of you to come over. My Valleywise folks who might be online, you guys are starting it over there, we hope. And this is a wonderful opportunity to not talk about the medical management of patients, but just how it feels to be in healthcare. We create a panel and people share their stories, and then the audience shares their stories of what it's like to be in healthcare. Here's some examples of topics we've talked about at St. Joe's before. When everything you have is not enough, carrying through a pandemic. The patient I will never forget, those ones are always powerful. Conversations on colleagues in crisis. We had people up at the panel talk about when their friend or their co-resident committed suicide, or their own thoughts of suicide. And they just shared that vulnerably with people. Stress, burnout, compassion, fatigue, when connection heals. I may or may not have something to do with the theme of that one, if you can guess. And people really shared vulnerably, and it opens up an opportunity for the people in the room to share as well. So, are they effective? You can look up all sorts of publications across the globe that Schwartz rounds is effective. Like, look at these outcomes. If we had a randomized control trial of a drug that had these kinds of outcomes, we would be making lots of money. But 90% reported better communication with their coworkers, feeling more compassionate towards patients and families, and feeling a reduced sense of isolation. That's really, really important. It's just an example of what we could do. Um, People at rounds, they like it. 99%. I hate that 1%. I don't know who they are, but I'm gonna find them. But they agreed or strongly agreed that it gave them deeper insights into the experiences of others. And they thank us and say, thanks for holding space for vulnerability that we could talk about this stuff. So I encourage you to come first Wednesday every other month, May 1st, Sontag. See you there at noon. So reflection doesn't have to be formal like Schwartz rounds. We can build in reflection. The medical students in the room know that we do lots of reflection because we are a Jesuit institution, but we can do this in our everyday experience. So reflection can look like monthly sessions with trainees, which we do with our medical humanities club, which we're able to just kind of talk about what it's like to be a medical student. And you can use approachable prompts like looking back over the past month. What's one thing that happened that stands out to you and why? And you get all sorts of beautiful stories and really, really painful ones. What's the most memorable patient encounter you've had recently? This is easy stuff. And people start sharing really profound thoughts. Can also look like for our faculty, making sure you're normalizing debriefs after serious events. I can't tell you how many times a medical student has come to me after their first code and said, there's something wrong with me. Why do I feel so much? But the rest of the team was ready to move on and we didn't talk about it. And how jarring that is. Existentially jarring to give chest compressions to someone and they die and you don't talk about it. So just remembering to normalize those experiences. It's really, really important with our students. And then at your faculty meetings, what if you started meetings off by spending like 5 minutes, someone sharing the most meaningful or the hardest thing that happened to them over the past few weeks? And really just making this a normal experience. This is low hanging fruit, easy stuff that we can start being more vulnerable. So I'm going to bring up my colleague, David, to lead us in a brief activity. Sorry, you have to participate. And we're going to talk about what it's like to connect. And those of you on Zoom, you will see Tom and I in just a second.
Beautiful. Thank you so much, Nikki. So Tom and Nikki performed that same exercise for our Zoom people, a little technical difficulty, and thank you guys for graciously doing that here. Some of you loved it, some of you probably hated it. I think there's two really important points to come out of that. Number one, hopefully, is that the currency of connection is emotions. Theoretically, when you share a fact with somebody, they're mildly interested, but when you share an emotion with somebody, when you share a feeling with somebody, they're deeply connected. And that's something that it took me a long time to learn. Historically, if somebody would ask me how my day was, I would tell them what I did. I'd be like, my day was good. I woke up, I exercised, I went to work, came home and walked the dog. And to me, that's what that meant. And I was spitting out facts. And eventually, through some trial and error and relationships, I learned that that's fun, but it doesn't really matter. What people want to know is what I did, that I was excited about, what I felt. This made me sad, this made me happy, this made me worried or scared. And that's what really caused the connection with partners, with friends, and with colleagues. That was really important. So the first point is that emotions are the currency of connection. And we need to feel our emotions and we need to express the emotions. The second thing is that it doesn't take that much time or effort. We sometimes think about the connection like the Schwartz rounds where you're dedicating an evening, you're dedicating an hour or two. But you can have a deep emotional connection with a colleague, with a med student, with a partner, with one of your nurses, just in 2 to 3 minutes, being like, hey, that was a really difficult patient encounter. That made me sad. That made me frustrated. Um, it's really tough. You know, it's tough to see somebody die. It's tough to have the patient being angry at you and it's not your fault. And just having, and it made me feel this, it made me feel that. And it doesn't take long. It takes a minute, it takes 2 minutes, or it takes 3 minutes. And that's all you need for the connection there. That's my portion of it. It's a pretty easy portion. I made you guys do all the work. On to Dr. Striegel.
Thank you, Dave. Thank you, Nikki. Thanks to all of you for allowing us to be a part of your day. This is content that was not part of my medical education. It was not part of my residency training. This was not something that was brought up in my practice afterwards. This is something that each of us individually had started recognizing in our own lives and our careers. And then we started having conversations amongst ourselves. So it's wonderful. It's become very synergistic as we put this program together, and it overflows into other aspects of our life. So let's talk more about connection. Let's break it down a little bit more, because we're really talking about 3 different types of connection, regardless of where we are. We're talking about being able to connect with ourselves, being able to connect with another person, and then how often with those connections, we create something that is much larger, something that is more universal and inclusive. So let's talk first of all about that connection with self. Dr. Vivek Murthy, who recognizes that name? Perfect, our US Surgeon General. This is part of their emphasis, their goals, their structure is to talk about connection, recognizing that loneliness in our culture is an epidemic, and it is a comorbid condition. So they address it. They address it on their website. They talk about it. He is the first US Surgeon General to have a podcast. And this is a quote from Matthew McConaughey. Who thought that they would be at a medical lecture where we talked about Matthew McConaughey, right? Where we talked about David Wooderson. All right, all right, all right. But he nails it. He nails it with this quote. We cannot connect with anyone else unless we are first able to connect with ourselves. So sit down and check in and be aware. Now, how about the name Brene Brown? Who knows Brene Brown? Oh, so a little bit of applause, right? A social worker and master researcher who looked at who we are as humans and how we are able to connect with ourselves. And it comes down, first of all, to connecting, to how we can connect with other people, but first of all, connecting with ourselves, being vulnerable and looking into dark places where it can hurt. So the graphics are from the Surgeon General's website. What's in the graphics, don't worry about. Go to the website, check it out there. What's most important are the items that I've highlighted here, the things that we can do, suggestions of ways that we can connect with ourselves. Meditation, mindful walking, all things that we consider to be relatively easy, right? We don't need a lot of resources, yet it's the first thing that we seem to cut out of our lives when we're feeling stressed, when we're feeling overwhelmed. But it pays off when we emphasize that. And what would our focus be? Being aware, as Dave said, of our emotions, of that currency, of what we're feeling, being able to access that and process that. And above all else, show ourselves some grace, show ourselves some understanding and compassion from within. And then when we have connected with ourselves, we're more open to connecting with other people. Now, who's a fan of Huberman Labs? Neuroscience. I love it because it's neuroscience that connects with somebody who's very simplistic like myself. And Dr. Huberman talks about this in many of his podcasts, the individuals that he interviews, and talks about how we are wired. Our very DNA helps us feel most fulfilled when we are connecting. And in fact, Dr. Barrett, whom he interviewed last fall, that's all of her research is dealing with our emotions, our neurochemical responses to stress, but also to connection. But don't take my word for it. Take their word for it.
Can you recap what they said? Because our friends on Zoom could not hear.
Okay, thank you. Thank you very much for pointing that out. So in the video clip that we just showed, we had Dr. Huberman and Dr. Barrett, two neuroscientists, and they talked about how we as human beings, through connection, are maintaining our stasis, our homeostasis. And it's not up for debate. It's not a matter of what you believe or don't believe. These are the facts. This is what they've proven. And being able to recognize when we need connection and to be able to do that with other individuals, whether that's colleagues, whether that's family, whether that's patients, or recognize when we can offer that to someone else and be able to help them be in their best emotional state. So that's a summary of what they just discussed. So now this is my opportunity to be vulnerable with you because I'm a languisher in recovery. And I didn't even know it. When I was practicing in emergency medicine in Iowa, outside of residency, and all we hear about is metrics and throughput, and you have stressful events that come up for patients and their family members, and you don't know how to navigate it, or maybe you do know how to navigate it, but it's different than what they want. It's complex, it's stressful. And I began languishing. I didn't know it. I didn't recognize it. Fortunately, I did recognize that there was something else in medicine that I needed to learn, that I was having conversations with patients and their family, and I felt like a phony because I was having them and I didn't know what I was doing. And that was conversations at the end of life. So it's with that minimal knowledge that I left my practice and completed a fellowship in hospice and palliative medicine, returning to the emergency department afterwards. And I didn't know that I was languishing even in fellowship. It wasn't until years later when I didn't feel like I was languishing anymore that I recognized it. And what was the change? Did my metrics change? Did my throughput change? Did the patients change? No. My perspective changed. And I recognized how connecting with patients and their families at very key moments in their life, very selfishly was healing me. It was that connection. It was those conversations that made me feel better about my job, that made me feel better about who I was, and allowed me to connect better at work and at home. It doesn't take much. It can be very superficial. It can be something in passing that lasts for seconds, or it could be something more dedicated, such as Schwartz rounds, or having key groups of people that you can meet with to discuss the hard things that we do. But when we make the time for it and we start to recognize that new emotion inside of us, that emotion of comfort, that emotion of safety, of well-being, that's when you recognize how powerful these connections are. That third connection, a connection to something larger. And I'm gonna bring it out. It's a medical lecture, but I'm gonna bring that word spiritual here. Who feels uncomfortable when I talk about spirituality in a medical lecture?
You're with the Jesuits.
Which is wonderful, wonderful. Doesn't matter what we call it though. If we use the word spiritual, if we talk about a universal connection, if we talk about something that is larger, it's still the same thing, regardless of the label that we put on it. And what does it look like? Well, for me, a languisher in recovery, this occurrence also happened last week completely unintentionally. I am working in our dedicated pediatric emergency department. I'm taking sign out from one of my colleagues. She had the worst day. An 18-month-old, cardiac arrest. They got the heart started again, but ended up losing pulses, unable to resuscitate. There are a few harder days in medicine than encountering something like that. And when she was talking about it, she was doing the things that we normally do to cope, right? She was talking about, well, you know, it went really well. You know, we did compressions consistently. We didn't have, you know, any additional downtimes. We thought about all of the things on the differential. And then I said, I hate these days. They hurt. And I hate how it hurts. And I asked her, I said, what will you be able to do tonight that allows you to heal and decompress a little bit? And she talked about going home. Unfortunately, or fortunately, her in-laws were going to be there, and she talked about the things that they were going to do. And she knew that she wasn't going to be able to talk about it in that moment, but there would be some additional times where she could talk about her family. And again, I said it, I hate that feeling. I hate how helpless it feels with those sorts of situations. And pretty soon I heard a nurse, because we didn't take it to the side. This was a very natural conversation that occurred in the box. I heard a nurse say, oh, I hate these days too. These are the worst. And then her colleague said the same thing. And the residents and one medical student was off to the side. And pretty soon we are all feeling the same thing. How hard it is to do our work, but how we can connect in that moment, even without a plan or without intention. And we can begin to heal through the connection with other people. So do you want to experience that right now? Another activity. Get out your cell phones. I know it's a lecture. I told you to get out your cell phones. Everybody get out your cell phone, okay? I'm going to get out mine as well. All right. So I want you to think of someone who has loved you unconditionally, someone who's always been there for you. And I want you to send them a text message or an email, short little note about how much they mean, or a simple thank you. Okay? Think of one person. Could be anyone. Everybody in Zoom land, do it as well. Think about those people who've been supportive when times have been difficult. And then when you've done it, Turn on your light. Turn the camera light on your phone. The flashlight, and hold it up. Hold it up so everybody can see. Exactly, starting to look like a Beyonce concert, right? Right.
Rachel.
This is it. This is what it feels like when through ourselves, we connect with another person and then create an environment of universal connection. Thank you. Thank you so much for doing that.
Thank you, Tom. You guys are good at making us uncomfortable and doing the hard stuff. This is what it's like being friends with them. I swear to God, they do this kind of stuff. Okay, so I want to wrap things up and give us just a minute or two to talk, but some things to take away. I hope that you can take away from today. So the antidote to burnout is connection and not going inward and protecting ourselves. That doesn't work and it makes it worse. Compassion is actually co-feeling and opening yourself up to the opportunity to feel alongside someone, which is scary and hard, but the exact thing that we need. And that if we want to reconnect, especially to ourselves, that's hard. That takes vulnerability and courage to connect to ourselves and with each other. If you want some resources about some of what we talked about today, or to go a little deeper, there's books and podcasts and videos and all sorts of things that you can use this QR code, and we'll share the slides with you guys so you can get that. And then finally, those of you who the intrinsic reward wasn't enough and you need an extrinsic reward, here's your CME. Do that and you can get your CME. Okay, so we have three minutes, and I would for any of the three of us, anything that's kind of like coming up for you, or what you want to ask or inquire about, or what this might mean for your practice or your training as a student, I just want to open it up, and we'll keep an eye on the chat too. Okay, this is Clarice, an M3, handing her the mic.
I would like any of your guys' advice on if you're a student in training and you're languishing and you are told to compartmentalize and they are basically not going to help you. How would you approach that?
Thank you, Clarice. Okay, if that was the advice you got when you were training.
So I think you can understand based off of our lecture today, you may politely inside of your head say, I disagree. And then lean into the resources you have on campus, lean into your friends, lean into your family, lean into those connections with patients. You are never alone. Every provider in medicine is experiencing these feelings at varying stages. One of the best things we can do, though, is pre-plan, is precondition. And that, when we talk about being resilient, when we talk about recognizing these connections, that's really what it comes down to, is preconditioning, having those relationships that are there, people you can trust, where you can be vulnerable, and communicate what is going on inside of you. I wish I could tell you that everyone in the medical community was completely on board with this. I think we all know the reality, but we are what's starting to make the change. We are making that difference. But find those people of like mind and connect with them and lean into them when things are tough.
Thank you, Tom. And thank you, Clarice, for that question. Always an insightful question coming from you. Okay, so what we'll do is we will wrap it up because we only have 1 minute left and I want to be respectful of your time. But for any of you in the room who want to hang out and chat, we will be here. We'd love to connect with you. And for those of you on Zoom, thank you all for joining us. We are grateful that you were here. So go and be well. and be open to connecting with others.